In this lecture, we're going to go through a case. You're called to see a patient who is unconscious and making a loud snoring noise. He's receiving 2 liters per minute of oxygen via nasal prongs and his saturation is 98%. Does this patient require any airway intervention? Yes, the snoring suggests he has partial airway obstruction. The normal saturation does not exclude obstruction, particularly in a patient receiving oxygen. It is important to realize that airway management can be extremely difficult, even for an expert, so call for help early. Start with a basic airway maneuver, the head tilt chin lift. Place your hand firmly on the patient's head and tilt the head backward on the atlanto-occipital joint. Then lift the chin by placing the fingers of your other hand under the bony part of the lower jaw and lift forward. As you do this, the tongue and anterior pharyngeal wall will be lifted away from the posterior pharynx. If this fails, then perform a triple maneuver. Tilt the head back in a similar fashion to the head tilt chin lift, then grasp the ramus of the mandible with the fingers of both hands and push it upward and forward. Finally, use both thumbs to open the mouth. Note that the head should not be tilted in patients who may have a cervical spine injury. In these patients, use a modified jaw thrust. This is covered in the trauma lecture. If these maneuvers fail, use an artificial airway. The Goodell airway is inserted upside down with the concavity facing the palate, and then is rotated into position. However, a Goodell airway is uncomfortable for the patient, and a patient who is not deeply unconscious may not tolerate one. In that case, a nasopharyngeal airway may be useful. Note that the nasopharynx passes directly posteriorly from the nares, and the airway should be inserted in the same direction, not superiorly. Returning to our case. Airway patency has been restored and confirmed by looking, listening and feeling, but the respiratory rate is low. The patient needs some form of ventilatory assistance, usually with a manual self-inflating bag valve resuscitator. Use of this equipment requires time and experience to master and will be covered in one of the skill stations. The equipment, which may need to be assembled, consists of mask, ideally transparent so the patient's mouth can be seen, which connects to an expiratory valve to prevent rebreathing of the expired gas. This in turn connects to the self-inflating bag, which is squeezed to ventilate the patient. At the distal end of the bag is a one-way valve, which allows oxygen to pass into the self-inflating bag, but prevents backward flow of gas when the self-inflating bag is squeezed. Beyond the valve is an oxygen inlet and a reservoir bag. The oxygen flow rate is typically set at 15 liters per minute. Check that the reservoir bag inflates. The addition of positive end expiratory pressure, PEEP, valves may improve arterial oxygenation and help to overcome airway obstruction due to laryngospasm. Pitfalls of mask ventilation include gastric insufflation and overdistension of the lungs. Gastric insufflation is common and increases the risk of vomiting and aspiration. In addition, severe intra-abdominal distension may cause cardiovascular compromise. If gastric gas insufflation is occurring, carefully apply cricoid pressure, which may prevent further insufflation. The volume of an adult-sized self-inflating bag is approximately 2 liters, and tidal volumes of 1.5 to 2 liters can easily be delivered by excessive squeezing of the bag. Rapid delivery of high tidal volumes can lead to gas being retained at the lungs and progressive distension and progressive rises in intrathoracic pressure. and these may cause profound hemodynamic instability. It's important, therefore, to concentrate on providing tidal volumes of only about 300 to 500 mils at respiratory rates of 10 to 16 per minute. Look at the chest as you squeeze the bag and check the chest is moving adequately. If it is not, check the airway is open and, if necessary, adjust the position of the head and neck. Alternatively, the seal of the mask against the face may not be adequate. If adjusting the mask position does not help, then use 2 hands to hold the mask and ask someone else to squeeze the bag. What next? Should we intubate the patient? Indications for intubation are the patient is unlikely to be able to maintain an obstructed airway, protection against aspiration, high PEEP or requirement for pharmacological paralysis, or need for frequent airway suction. It's important to understand that airway obstruction due to an anatomical lesion, as opposed to decreased consciousness, is difficult to manage, and you must find expert help urgently. In particular, patients with an obstructing lesion in the oropharynx or larynx should not receive paralyzing agents, as there is a high risk of failure to intubate and failure to ventilate. The urgency of the situation must be considered. The patient may need to be intubated urgently, but may not need to be intubated immediately, allowing time for help to arrive. The urgency will depend on the situation. For example, a patient with very severe hypoxia will require intubation more urgently than the patient that requires intubation to prevent aspiration. Other considerations are your own personal level of skill and the anticipated difficulty of intubation. Before attempting intubation, always assess the patient to determine whether intubation is likely to be difficult or not. Clues to difficult intubation include neck swelling or short muscular neck, decreased distance between the chin and the thyroid cartilage, less than 6 centimeters is worrying, a beard. This frequently hides a receding chin and makes bag mask ventilation more difficult. Lower incisors that are anterior to the upper incisors or protruding teeth, a small mouth or limited mouth opening, severe facial trauma, high curved palate, large or swollen tongue, and limited neck movement. If you think intubation will be difficult, call for help immediately while continuing with basic airway techniques and administration of high flow oxygen via bag valve mask resuscitator. Prepare the equipment for advanced airway techniques and wait for help to arrive. However, if the patient develops complete airway obstruction or cardiorespiratory arrest is imminent before help arrives, attempt an advanced airway technique yourself. The choice of technique is dependent on the situation and your skill in performing the technique. Our case has no features suggestive of difficult intubation, and we decide to go ahead with direct laryngoscopy. Had the patient been conscious, it would of course have been important to obtain verbal consent. We start by assembling the appropriate equipment and making sure it works. The equipment should include intubation equipment, monitoring, suction, bag valve resuscitator, and artificial airway. Intubation equipment includes 2 laryngoscopes with at least 2 sizes of blade, endotracheal tubes, forceps, stilette, bougie, and syringe. Note that a laryngoscope blade has both horizontal and vertical parts. The vertical part allows the operator to move the tongue to the left. The horizontal part allows the tongue or epiglottis to be elevated at the appropriate time. Check that the light works and is bright. We will also need drugs, including an agent for inducing anesthesia, muscle relaxant for producing paralysis, oxygen, a sedative to keep the patient sedated when the induction agent wears off, resuscitation drugs, and fluids. Administration of these drugs requires reliable IV access. Check that a cannula is in place and is working. Assistants are crucial. It is not possible to safely intubate a patient on your own. Before starting, make sure that each person is clear about the role he or she needs to play. Typically, there are three main roles: drug administration, passing you the equipment, and cricoid pressure. The person giving the drugs must be given clear instructions on what drug to give, how much, and when. The person performing cricoid pressure should not be given any other role. During laryngoscopy, these are the important landmarks you're aiming to see: the epiglottis, the vocal cords, and the arytenoid cartilages. Most ICU patients are at risk of aspiration of gastric contents during intubation, and therefore rapid sequence induction and intubation is required. This minimizes the risk of aspiration by minimizing the time between loss of consciousness and intubation, and by the use of cricoid pressure. Start by positioning the patient with the neck flexed. This is best achieved by elevating the occiput by about 7 to 10 centimeters with a foam pillow or wedge, and extend the head. Positioning is crucial to the success of the procedure. Then pre-oxygenate the patient with 100% oxygen for 2 to 5 minutes. Give a predetermined dose of induction agent and paralyzing agent, giving the paralyzing agent without waiting for loss of consciousness, and apply cricoid pressure as the patient starts to lose consciousness. To find the cricoid cartilage, first find the thyroid cartilage. Moving caudally, you will then feel the cricothyroid membrane and then the cricoid cartilage. To apply cricoid pressure, place one finger on the center of the cartilage and one finger on each side, pushing the cricoid cartilage backwards to occlude the esophagus. Pick up the laryngoscope in your left hand and turn it on by extending the blade. With the head and neck in a good position, advance the laryngoscope blade gently along the right-hand side of the tongue, pushing the tongue to the left until the tip of the epiglottis is seen. Continue to advance the laryngoscope to the base of the epiglottis. Note that the laryngoscope blade is in front of the epiglottis and not covering it. Lift the laryngoscope in the direction of the handle to reveal the cords behind the epiglottis. Do not look away from the cords. Insert the endotracheal tube from the right with your right hand. Measurement of expired CO2 by capnography is an accurate way to confirm the tube's position in the trachea. Carbon dioxide is only produced in the lungs, and therefore only expired gas can contain carbon dioxide. Note that in a pre-oxygenated patient, the saturation may remain high for some minutes, even after mistaken esophageal intubation. Capnography may produce false positive results, i.e. detectable end-tidal CO2, were the first few breaths after inadvertent esophageal intubation as a result of gastric insufflation from prior mask ventilation. A false negative, a decrease of very low carbon dioxide despite correct position, may occur with cardiac arrest without CPR and low cardiac output states. Clinical signs such as auscultation of breath sounds over the chest and epigastrium are useful but less reliable. Auscultation is, however, useful to detect a tube that is too deep and in the right main bronchus. In most men, the tip of the endotracheal tube will be appropriately deep when the tip is 23 centimeters from the front teeth. In women, 21 centimeters. Secure the endotracheal tube carefully with tape or ties. The risk of failed intubation is about 1 to 5%. This may be catastrophic if it is unrecognized or if the patient cannot be adequately oxygenated by bag mask ventilation. It is therefore essential to have a plan for a can't intubate, can't ventilate situation. This is an example of a very simple algorithm for endotracheal intubation failure. It can be found in your course manual. However, if your unit has a standard algorithm for this situation, use that instead. A simple technique that may be useful in this situation is ventilation through a laryngeal mask. The laryngeal mask airway is prepared for insertion by completely deflating and smoothing out the cuffed rim to be wrinkle-free. The posterior surface and the patient's hard palate are lubricated with water-soluble jelly. Position the patient as for endotracheal intubation with flexion of the neck and extension of the atlanto-occipital joint. The laryngeal mask is inserted with the tip of the cuff continuously applied to the hard palate and with the right index finger guiding the tube along the back of the tongue until a firm resistance is encountered. The cuff is then inflated with 20 to 40 mL of air. In summary, maintaining a patent airway is a life-saving skill. The timing of intubation depends on the indication, anticipated difficulty, and your level of skill. It is vital to prepare your equipment, drugs, assistance, and the patient.